So with that, I would like to introduce you to our first speaker of the night, Dr. Michael Gardner. Dr. Michael Gardner is a native of El Paso. He joined the Harris Health as Executive Vice President for Ambulatory Care Services in September 2015, and he's responsible for 18 primary care and pediatric clinics, 6 same-day clinics, and multiple specialty clinics, as well as 14 pharmacies, 2 oncology infusion centers, a freestanding dialysis center, and a radiation treatment center. He manages all the outpatient services for Harris Health, the 3rd largest safety net system in the United States, which serves approximately 300,000 patients a year with over 1 million annual visits. Dr. Gardner was previously a chair of an academic OB-GYN department in Tulsa, Oklahoma, chief of the OB-GYN services at Grady Memorial Hospital in Atlanta, and an endowed professor at Emory University. He received his medical degree from Texas Tech in Lubbock, has a master's in public health from the University of Alabama, and a master's of public management from the University of Southern California. Please join me in giving Dr. Michael Gardner a warm welcome.
So usually I'm not accused of being difficult to hear. My team who's sitting at the table will attest to that. But just in case this is a rare night, I'll use the microphone. Thank you for the kind invitation. This is an interesting topic for us. This is where we're going. We're going to talk a lot about things we're doing, but also things that we want to be doing in the coming years. We're actually in the middle of, when I say we, Harris Health, we're in the middle of our strategic planning process that we're calling, that my boss, George Massey, who's the CEO of our system, calls the Bridge to 2020. And we'll talk a little bit about that, and we'll talk a little bit about how that is involved in this topic. Yeah, that's it. Oh, am I blocking the all right, sorry about that. They weren't that important slides. All right. So, what are we talking about? Now, again, it occurred to me relatively recently that at 56, that 32 years ago I was an intern, which is kind of painful to even think about that. I've been doing this for a little while. And so the model has certainly changed in my professional lifetime, and it makes me feel a lot older than at least chronologically I'm supposed to be. And when I was a medical student, when I was a resident, certainly we had rounding teams, and those rounding teams were physicians that went around and saw the patients. Occasionally the nurse on the floor might walk up and ask things, but we obviously still have paper charts. There are days I sometimes miss those paper charts, even though we're a fully integrated system in Epic, and I still do. Day after tomorrow, I'll be at the high-risk OB clinic. I'm maternal fetal medicine by training, by the way. I'll be doing the high-risk clinic at Ben Taub, so I still do a modicum of clinical work. My wife, who's a full-time MFM at UT, says I'm a student, but occasionally I still get to be, once a month I get to be a doctor. The nurses then did most of the care, and notice that all this I'm talking about is inpatient. That was all where our life was about. It's all we thought about. Clinic was almost an afterthought. Clinic is where we had to go so we could have patients on the inpatient side, so we could do surgery, so we could do the fun stuff, deliveries and those kinds of things. Outpatient was really something else. You know, in Texas, there was a big resistance in Texas over the years to require that the title nurse was a professional title, because most physicians in private practice, you could be a high school graduate at 18 and quote unquote you're a nurse, and that was the way it was for many, many years. And then as we moved along, we started, I would say maybe in the 90s, we started thinking about some multidisciplinary teams. But those multidisciplinary teams was clearly still captained by the physician, whether that was in an academic center, that might be the chief resident or attending, or in private practice, the attending is rounding. You would still have nurses, but now nurses would actually round with you on occasion. You might have, and this was considered really, really forward-thinking, now it's kind of considered but at the time it was considered really, really forward-thinking, that you might have, particularly on internal medicine or pediatrics, a clinical pharmacist with you. That was like really cutting edge in the 90s, all right? And then came case managers. And the reason why case managers came is because that was at the same time that managed care was really coming into play. All right? Even though HMOs, there's pros and cons to HMOs. HMOs actually, for those of you who like the history of our country's medicine, anybody want to, who was the first person to really push HMOs in our country? Anybody remember that? Richard Nixon. That was Richard Nixon's gift to health policy. He thought HMOs would be a way, in 1971, pre-Watergate, he thought that would be a way of controlling costs. So some of these discussions, I point that out, one, because it's kind of, you really don't think of Nixon and HMOs. But also, it just shows how long we've been talking about controlling costs. We weren't very good at it in 1971, and I would argue now here in 2017, we haven't got a whole heck of a lot better. But with the advent in the 90s of HMOs, case management became an important thing. But why? The whole point of having case management was to get the patient out and try to prevent them from being discharged, from being readmitted. It was all about saving money for the insurance company. And also for keeping the hospital and the physicians, given the fact that the care was capitated, to try to make it to where doctors and hospitals could still make a living. There's nothing necessarily inherently wrong with that, but it still isn't necessarily what we want to do for case management and what we want to do about multidisciplinary teams. How many of y'all live in Harris County? That is much higher than my crew. Okay, I happen to live in the Heights, so I really didn't mind coming here because it's less than 2 miles from my house here. So so for those of you who live in Harris County, you own Harris Health. You pay taxes, and so I'll tell you a few things about that. First off, slightly less than 50% of our $1.4 billion budget, which is third, or fourth, or fifth in the United States. Parkland is almost as high as us in money, although we see more patients. I would argue you get a better bargain than Parkland, than Dallas County does. Some of that, about 45% of that budget comes from property taxes. So those of you who live in Harris County, you own it. So let me tell you what you get for your money. First off, let me point out to you that the taxes you pay at 17 cents on a $100 valuation is the lowest in the state. If you live in Dallas County, it'd be 26 cents. If you live in my hometown of El Paso, it'd be 21 cents. In San Antonio, it's 24 cents. So please, you can hate the rest of your property tax bill, but when you see the part for Harris County, remember that that's going to really good purposes, okay? We have, depending on how you count, we have 15 community health centers. Many of you are familiar with these: Martin Luther King, Senegas, Squatty Lions up in Humboldt, Baytown, El Franco Lee down in far southwest Houston, Acres Home, Northwest Clinic, all these, many of these clinics, Casa de Amigos, many of these clinics have been around for almost 50 years, right? We have 6 same-day clinics. These are newer clinics that we've had with District in the last 4 or 5 years. We have 4 specialty clinics. We just opened our new Bentop Tower. For any of us who trained at Bentop, remember what the second floor used to be like with the clinic with this big, huge mass. That's gone now. All the clinic facilities are really nice facilities. For people who trained in the old Bentop, it's hard to believe. We have Thomas Street. Thomas Street, which we argue is the oldest HIV standalone clinic in the United States. There's a clinic in San Francisco that disputes that. Of course, they're wrong. It's us. And so Thomas Street still does an unbelievable amount of work in the HIV/AIDS research and is heavily grant funded. The homeless program. Many of you know about healthcare for the homeless in town. They do about 6,000 visits a year. They do wonderful work. Our homeless program does 10,000. Most of you don't even know we have a homeless program. Okay? So really, if you put all the homeless healthcare programs in Harris County together, they almost do as many visits as we do. Okay? And Dr. Quadri and her group, they do unbelievable work. In fact, just today we found out that we're getting an extra $70,000 because of the quality work they're doing. Just some really incredible stuff. The other thing I'd point out, and this is a sad statistic, of all the clinics I have, and if you add them up, they're over 40. My homeless program, or our homeless program, has the highest percentage of U.S. citizens of any clinic that I have. Now think about that statistically. That's a sad statistic. It's almost 100% of our homeless patients are U.S. citizens. We have school-based clinics, Riverside Dialysis. We have a freestanding dialysis center. That is, out of 116 patients, 164 are undocumented. Because it's what we do is if you can get Medicare, we send you to private dialysis, and so we're a place of last resort. We're actually just starting, for those of you who are interested in dialysis, a peritoneal dialysis program for our undocumented folks to try to save costs. And we have 2 outpatient infusion centers and several dental centers. I'm telling you that so you know what you're getting your money for. Because many people, when they think of Harris Health, they know about Ben Taub and the trauma center. I love Ben Taub. I was chief of OB there for 6 years. But we do a lot more. Okay. This also just sort of shows where we're at. And in the blue, in the far lower, in the lower right corner, the blue is precinct 1. That would be Commissioner Ellis's. Then the red, that would be Commissioner Mormon on the east side of town, Baytown, Pasadena, that area. The green is Commissioner Raddick at the west side, southwest of Katy. And then the purple is the middle that goes up to Tomball, and that's Commissioner Cagle. So that just gives you a sense of where it probably doesn't shock you that the majority of our places are either in East Houston or in the central core that Commissioner Ellis has, because that's where, we don't have any clinics near roads. Okay? The other interesting thing that's fascinating, if you look at the red dots that you see there, I don't expect you to memorize this map, all the other things that aren't red is us. In 2001, there was 4 FQHC's clinics in Harris County. I was on the phone with Lone Star from Austin this morning. They're working with the University of Houston to open a new one in the 3rd Ward that'll be associated potentially with the new University of Houston Medical School. They're hoping to have that open by next year, but that'll be about 45. 45. We've gone from 4 to 45, give or take a couple, FQHCs in the last 16 years. So obviously, that's adding a lot of capacity for primary care for the underserved. That's a wonderful thing. And this just confirms what the kind of people we see. The visit volumes last year, we had 575,000 primary care. We had 650,000 specialty care. Just to give you a sense, again, I'm giving you this context partly because I have 2,000 employees that are unbelievable, including these people right here, that make me look good every day. But also because since most of you live in the county, and again, you know about Ben Taub, and you know about the trauma center, but you really, many people don't realize how much what your tax dollars are doing. And it's doing some pretty incredible things. Okay? And we talk about immigrants, and I happen to be, from the border, so it's an interest. We take care of on the outpatient side. About a quarter of our patients are undocumented, and about 15–16% are documented immigrants. So we have a large immigrant community. We also have a growing at El Franco Lee, which is in southwest Houston. We have a larger and growing refugee population from Afghanistan, Syria, Iraq. Again, I'm seeing some of the looks. It's like in Houston. Yeah, in Houston. We don't. For the obvious political reasons, I was born in Denton and grew up in El Paso, so I understand the politics. We don't talk about it a whole lot on the newspaper, but we're actually doing the care, and we're very proud of it. Okay? So now that leads to what we're trying to do differently, maybe a new way of thinking. And I really want to have a few slides, because I figured most of this should be about questions, not about talking. We want to get to a point where we think, and this is going to overstate it for hyperbole's sake, that getting into a hospital, being admitted to a hospital, is evidence of a failure. Now, in my particular specialty, we're not going to be doing outpatient deliveries, and I'd like to think that delivering a baby is not a failure. My mom did it, your mom did it. I'm hoping the moms are going to do it for a long time. The species has done well. That's why moms, because if they'd been dads, we would have been extinct about 2 million years ago, because we wouldn't have done it. But for the most part, if you think of hospitalization, it should be the choice of last resort, right? If a trauma happens, it's because somehow we broke down in gun safety, or we broke down in automobile safety, or we broke down in some kind of plant safety. If a cancer happens, perhaps that's a breakdown in cancer screening that we could have prevented. Or if diabetes is happening, is that because we're not preventing, particularly type 2 diabetes? Is that because we're not preventing obesity and we're not teaching enough about exercise and lifestyle at a young enough age to maybe hold that off, right? And we joke in our group that when we look at Harris Health at least for our primary care population, our three biggest problems is diabetes, diabetes, and diabetes. And that's what we really spend a lot of time there. If you look at this, we want to get to where we're dealing with wellness first, prevention second, then disease management, and then when all that fails, then we go to acute care intervention, i.e. hospitalization. Okay? That doesn't mean for my surgical friends that we're never gonna stop doing some surgeries. I feel like that as long as people get together, my specialty in particular is a safe thing. I feel pretty good about that. But we want to try to do more and more on the outpatient side. The economics of this is going to demand it, right? We're going to have to do more and more and more on the outpatient because frankly it's cheaper. And some of the systems, as you see, you guys have read all the headlines, some of the systems that are building hospitals as fast as they possibly can, they live to rue that day. Because, you know, paying for those beds, paying for staffing those beds, it's going to be harder and harder, right? So data sharing, we've got to get to this place where, I mean, it's ridiculous that I can travel anywhere in the world, that you can travel anywhere in the world, and your information that you need is available through the internet. But you can't go across the street from Methodist to Herman and get the ER record that you had the day before. I mean, it's just, to use the medical term, asinine. And it's not like it's a complicated technological solution. It's just people getting together and saying, we're going to do this. And you know, you guys know about Greater Houston Health Connect and those kind of things. That's a start. But really, at some point in time, you know, you got to figure that someday we're going to have a unified medical record, right? You know, that we're using the same platform. We don't have 85 different versions of Microsoft Word, right? Even though some of us remember the Word Perfect was actually a better program, but we all use Word because we like to be able to send stuff to each other. We all use PowerPoint because we like to send stuff to each other, right? It makes more sense. Patient education, community engagement. These are some of the things that we're looking at. In Baytown, for example, we have 10 acres of land. I don't know why we have 10 acres of land. There's some deal that happens that we have. So I spend, my budget's it's not going to come out of my pocket, $1,400 a month to mow that 10 acres. Okay? Now that just bothers me because I can take that $1,400. You know, that's almost a salary of a medical assistant that I'm spending on mowing a 10-acre land. Makes no sense. We're actually working with the city of Baytown with a grant that came from Exxon of turning that into a community farm and putting an exercise track in the middle of it. You know, and just saying, we'll put a fence up between that and our clinic, say, you guys take the land, you know, it'll still be our property because, you know, we're a public entity, but working with the city and such, let you all use it and let other people fund it, do vegetables, maybe do some teaching about how to cook with vegetables, those kinds of things. And I don't have to pay the $1,400 a month to mow it anymore, right? So coordination of care, trying to work with our partners, trying to work with different teams. We're going to talk a little bit more about that. And we don't do anything. All of our physicians are UT and Baylor physicians. My wife is a UT faculty member. She's on call at LBJ even as we speak. You know, we don't do anything without our physician partners. Okay. You know, if University of Houston ever opens its med school, maybe there'll be a third partner with us. You know, and that would be a good thing. But we can't do anything without our physician partners. But likewise, our physician partners can't do anything without us, right? I mean, you know, it's a symbiotic relationship, and we have to all work together. So let's get more specific. So it's easy to say, I'm for prevention. It's like, okay, well, raise your hand if you're against prevention. Up until this last weekend, I used to joke because I border on politically incorrect. I said, you know, you have to be really careful what you say, but there's one group that you can always pick on. You can say anything you want and nobody gets upset. Nazis. No one ever defends Nazis until this weekend. I thought that I would never see that I'd never have to eat my words. I've been saying that for years. Anybody, you can always get away with picking on the Nazis. No, until this weekend. Okay, so I stand humbly corrected. But I still think you can pick on Nazis. Right? I still think they're bad. All right, so with prevention, so just like we can say we don't like Nazis and we do like, you know, mom and apple pie and the 4th of July, we all agree we like prevention. We're all for wellness. Well, okay, now do something. Well, doing something is really getting into the community, which we actually now have We're just starting the program with people going to people's houses with diabetes and actually looking at the food they have and what kind of cooking they're doing. And we have a program, another one I'll show you in a second, wellness initiatives where we're going to build a track at Acres Home. The first thing we had, this is the practical stuff. We had to put up a fence because we had pit bulls and other dogs running onto the area at night. People were afraid to walk there because they were vicious dogs. So the first thing we did is we spent money to fix the fence so dogs can get on. I mean, it's just practical stuff. And we got a grant and we're building we already had a track that we're expanding, and we're spending $16,000 on lights? $16,000 to put lights around, and we're going to pay for the security guards to stay a little later once daylight saving time goes away, so people in the community have a safe place to walk. You know, we're not talking about making people marathoners. If we can just get people to come out and walk 20 minutes, push their baby in a baby carriage for 20 minutes, take their mom or their father out for a walk for 20 minutes, that's money well spent. And you could probably argue the ROI from the health system will pay off, right? So these are the kinds of things we're talking about. Obviously, tobacco-free lifestyle, and so we're still, smoking is probably the lowest level it's been in years, but we're still pushing that. Preventative screenings, we're doing a lot more of that. We just this week, you guys have no idea what big deal this is for us. We've been trying to get, there's some magic number of 64% for annual screening for colorectal cancer. Now why that number comes up, that's just what HEDIS, which is a national number, picks. We never could hit it because most organizations do that by using every 10-year colonoscopies. We can't afford every 10-year colonoscopies. We still do annual fecal blood tests. We came up with a new test that we actually send it in the mail, which I remind people that there's a whole meeting about if you're getting crap in the mail. But with that, just this week, I don't even know if you guys know this, we finally hit 64%. 2 years ago, we were at 40. And people said, you will never, ever, ever get to the national average in screening with your, well, we did. Just this week, we got there for last month. Okay, that's it. And guess what happens? We're screening a lot more people. So guess what happens when you screen a lot more people? You get a lot more screen positives. So we actually now are having to outsource more colonoscopies. But we picked up a couple cancers. Now, so in the short term, if you only care about money in the short term, you say, well, that was the dumbest idea. You know how much money we're spending outsourcing all these colonoscopes for all these colonoscopies to East Texas regional? Yeah. But the pro is that in the long term, we're preventing cancers, which will cost the system a lot more. Okay. So then you go into medical home, which we are really trying to do. We've gone from a system where the chances of you seeing your primary care provider on a visit was a coin toss, 50-50, to where now you're seeing your own provider 85% of the time, which we think is really going to improve the relationship with the primary care provider and their patients, the infrastructure, and then of course we still have that specialty care. One of my missions is to balance specialty care with primary care. Harris Health has been really, really good at inpatient care and outpatient primary care, and we kind of sucked at outpatient specialty care. You know, we have some clinics that, some services, the wait time is over 200 days. Our goal is within the next 2 years, is not to have any wait times more than 120 days, preferably less than 90 days. We're already about 70% there, okay? But we still have some services and some places to go. Cancer care, MD Anderson says we have the second best radiology center in Harris County. We think they're off by one. Our dialysis center, which you can imagine a dialysis center that's principally for undocumented, you'd say it's not exactly, if you've been to Riverside, it's not the prettiest building. Our mortality rate is 1/3 that of the national average, 1/3 lower, 66% of the national average. So the care that's being provided, again, with your money, is outstanding care. Maybe not in the prettiest buildings, maybe not in the nicest neighborhoods, but it's really good care. So these are the kinds of things that we're working on. I want to just give you one more, a couple of examples, and then we'll be done. For example, we have an OB Nurse Navigator program that actually works with people who have risk of preterm birth and walks and coordinates their prenatal visits, coordinates their ultrasounds. We've found that first off, they're much happier. Second off, they're much more likely to deliver in Harris Health. And we've seen some improvement in outcomes. Small, because preventing preterm birth, I can tell you it's not as easy as one simple answer, but we have made some improvement. We work with MD Anderson on the Yes We Can program, which is an outreach for kids to try to, using childhood obesity prevention programs, talking about activity, about diet. And again, when you go to any place in Houston, it's tragic the number of kids we see that are already who are already obese, because we know it's very, very difficult if you're obese when you're 12 to have a healthy lifestyle when you're 30. It's not impossible, but it's very, very difficult. It'd be so much better if we could prevent that obesity to begin with. Health educators, we talked about this. This is one of Jamie's favorite things. For people that come to have diabetes, and they come to our nutrition and they follow come to a couple of visits, follow advice, we'll take them to a grocery store with some vouchers and we'll shop with them and get a $30 healthy shopping cart. We help them pick good things. So this is a very popular program. Fresh Foodies is it? Yes, Fresh Foodies. Thank you. And we just got a grant from Episcopal Health Foundation to talk about the community center health homes. Some of the other organizations now we're working on this. The Acres Home Track I talked to you about, part about that. We're also trying to partner with other organizations, perhaps YMCA and other things, to talk about exercise as well as lifestyle. So these are some of the things that we're doing right now, and that's the kind of coordination care. Notice that a lot of that stuff has nothing to do with traditional doctor sitting in front of a patient, patient sitting in front of a doctor at a visit, which is still critical, still crucial. But these other things we're hoping is going to make that care easier, make that coordination of care better. We now go to our primary care doctors electronically every time one of their patients come to the ER or get admitted to try to cut things off the path. And we're really working hard to try to decrease the number of patients who need that acute intervention, who need to be in the hospital and such. So now our multidisciplinary, this is the last slide, our multidisciplinary teams. You have physician champions, and we still need the physician champion. At the end of the day, no one says, I'm going to see my fill-in-the-blank visit. People say, I have a doctor's appointment. Our patients still want to see a doctor. Our patients still want to feel like they have a primary care provider that they can trust and they can depend on. But he or she can't do it alone. The patient education, the nursing education and support from nursing. Our nurse, we are now, like everybody else in town, doing universal screening for food insecurity questions. And we're working with the Houston Food Bank to have, for a couple of our clinics, to see if they can bring food there as opposed to just referring them to the food bank, having the food bank come to our clinics with people who have food problems. Nutrition with that clinical pharmacy, we have a lot of really good work with our clinical pharmacists, particularly in the area of diabetes and hypertension, and clinical case management. But now the clinical case management isn't about just keeping you out of the hospital. Now the clinical case management about, let's go over the social determinants of health that are having problems. You have housing problems. Let's see if we can help get you to the right place with that. If you have food problems, we discuss that. If you have other things, let's see if we can do what we need to do to get you the kind of care you need. Now, we have a limited budget. We're not, by no means have we solved this, but this is what we're trying to do. This is where we're trying to go. So I appreciate the opportunity to talk about my incredible people that I have that work with us. And, again, I'm lucky enough to have 2,000 employees who are very, very dedicated to the healthcare for the people who most need it here in Harris County. And thank you for your time.
Okay, so now we're going to go ahead and open up the floor for questions. We'll have a circulating mic,
Hello, hi, how are you?
Good, thank you.
One of my questions is, how do you convince people who are in leadership to invest in these type of interventions? How do you convince like the leaders of the community, the leaders within your hospital institution or whatever institution you work for, to invest in some of these initiatives and projects?
Well, I'll give you a short answer and I'll press on. In our organization, thankfully, I work directly with the CEO. Some of you know Mr. Massey. He's been now CEO for 3 years. He's been with Harris Health. I met him when he was here, when he came in 2001. And he's very passionate about this and thinking that Again, for those of you who trained at Harris County Hospital District back in the day when we were still the district, you remember rooms of 4 beds in a room. All those are gone. They're all semi-private and such. Well, why does that matter in this conversation? By definition, that's the right thing to do, but we decreased beds significantly both at LBJ and Ben Tom by doing that, right? So one of the things we did this for is out of necessity that we're going to have to be more parsimonious with our in-hospital use. There's only one way of really doing that is by keeping people out of the hospital and trying to prevent those kinds of things. We do think, and when you look at, I guess, finances, there's no question that finances drive things. So when you look at what CMS is trying to do, one of the phrases that gets bandied around the most and is often, we use it the way some people use scripture, kind of however they want to say it, is value-based healthcare. Okay, when you really read the book on value-based healthcare, it's very different than how some people describe it. But that said, the idea that I think we really are finally moving to a place where we're going to get paid on the quality of the work we do, not the amount of the work we do, which clearly is a necessary change. It's been a necessary change for a long time. I think will drive people to want to do more of these things. Because if you're going to be held, another phrase gets bandied around a lot, of course, is population health. If you're going to be held accountable for that population, you're going to have to do these kinds of things. And if you're in some sort of a capitated kind of environment, this kind of stuff is just good. If you don't do this kind of stuff, you're going to go broke. So I think that's, I know I'm emphasizing the money there, but for people that are trying to make payroll, you're going to have to show them that the investment makes sense. And I do think we're moving that. By the way, did any of y'all see that for the first time ever, there was a poll that came out today, which shocked me, kind of shocked me. 70,000 physicians across the country asked one question: do you favor a single payer plan? First time ever, 52% said yes. Again, when I was a first year resident in 1985, that number would have been 5%. Okay, so I do think that there is, rightly or wrongly, there is a shift in the way we're thinking across the country and in our profession.
Any question over here? On your community engagement, are you thinking about including some of the community members, like the faith-based groups, and also some of the other, I think they're non-profit hospitals, partnering with them to do some of this community engagement? Like I know out there in Baytown, Methodist working on something out there too, with the same group, with the transition of care. So see if maybe y'all can get together with that. That's all I need.
So on the outpatient side, so the answer to your first part, as far as community groups and faith-based groups, for example, we did a huge. There was a movie that came out last fall about prostate cancer in African American men, and we did instead of we did 200 plus prostate cancer screenings in one day. It may have set a record, and for the people that were qualified with high risk, we actually also did a lot of PSAs and found out of that group we found 4 previously undiagnosed cancers. So that's an example of something we've done. We are working with other groups. Now, hospitals we're not working with as much, but where we are really trying to partner is with the FQHCs. We know that we can't see all the underserved primary care in Harris County. And the number one complaint of my primary care doctors, the number one complaint of physicians at the FQHCs is lack of outpatient specialty care, the ability to refer. So we think that it's highly likely that we're going to maybe even decrease a little bit our primary care footprint, hoping to partner with the FQHCs so that we can take, because we don't really expect us to get more money. We think our budget's going to be just, y'all are really loyal, but so far, I haven't seen anybody walk around with a sign saying, raise my taxes, raise my taxes. Not a common thing to see. So we think we're going to shift some of our resources more into specialty care, outpatient specialty care. We just did some budget changes where we're going to recruit 2 more neurologists, 1 for UP, 1 for Baylor, and they'll be essentially completely outpatient. Same thing for rheumatology. Rheumatology and neurology for our patient population, sometimes the wait to get an appointment can be 6 months. So those are the kinds of things. So with the FQACs, we are trying to work with them.
And I was asking about the faith community nurses. That's a specialty. And I know that Parkland and Texas Health Resources use it a lot. They use the churches and they use the community. The hospital pay for faith community nurses, but the nurses at the churches are volunteers. They've been doing it like 12 years.
Well, what the look at the program? Yeah. We're totally cool with copying.
All right, maybe one more question.
Do you have any programs to identify or treat high utilizers in the system?
Why don't you ask that? Yes, there was a district project that we tried that and didn't really feel like it was completely successful. Some of you all know Dr. Buck, David Buck, and we're working with him on looking at a model for that. We do identify our high utilizers, and we do, one of the things with case management is get them into a primary care, particularly, well, we have 2 groups of high utilizers. The minority of people who have a PCP, but for whatever reason that isn't working the way we want it to work, and we'll get them in to try to tune up some care. We have some gaps. I will tell you, we found that we have a small minority of physicians who have patients that they've been refilling diabetic medicines for months without seeing the patients who have abnormal hemoglobin A1Cs. So we're not perfect. Okay, we have, but for the first time we've actually identified and said, hey, you know, you can't do that, right? You just can't write month after month after month prescriptions, you know, and not see. So that's one group. The second group are people that come that are high utilizers to our ERs who do not have a primary care provider, do not have a medical home, and we are finding those and offering them appointments. I will tell you something that's frustrating. We get appointments for people coming out of the ERs. I think we try to get them in less than 7 days. We certainly do it in less than 14 days. We have about a 48% no-show rate for people who went to the ER, and even though we're giving an appointment in less than 2 weeks. Now, some of that is understandable. If you went to the ER because you had the flu and you feel better, and particularly like most of our patients, they work, but they work for an hourly job, going to see someone and say, yeah, I feel better, just means I lost a half day's pay. Okay? But there are other people, probably the people you're thinking about, hypertensive diabetics, people who are borderline renal failure. We really need to get them in and get care. Again, it's a failure when they come to the ER. We need to get to the sense that that's a failure of our system. And so we're working on that.
Thank you very much, Dr. Ritter. If you have additional questions, I think we'll have a little bit extra time with the panel discussion at the end, but we'll proceed to our next speaker.